Hi, and welcome to Ethnographic Imagination Basel, a series on reimagining the world from the mundane. My name is George Meiu, and this episode will be on birthing, that is, the process of giving birth. Our guest is Stephen Okumu Ombere, who has researched birth in relation to medicalization, social assistance programs, and motherhood. So stay tuned for a conversation on how birthing can help us reimagine the world. Stephen Okumu Ombere is lecturer of anthropology at Maseno University in Kisumu, Kenya, and postdoctoral fellow at the Center for Advancement of Scholarships at the University of Pretoria on a project called Reimagining Reproduction. He is author of 2 monographs: The Socio-cultural Context of Circumcised Men's Sexual Behaviour in Kenya, published in 2015, and Local Perceptions of Social Protection Schemes in Maternal Health in Coastal Kenya, defended as a PhD dissertation at the University of Bern in 2018. Stefan has also authored and co-authored articles applying a medical anthropological perspective to a wide variety of topics, including circumcision, HIV/AIDS, maternal health, and children's vulnerability to sexual abuse. Stefan, a hearty welcome to Ethnographic Imagination Basel. It's a pleasure to have you here.
Thank you so much.
You have done extensive research on the rise in the last decade or so of social assistance or social protection programs that attend mostly to women who are poor and to their birth-giving practices. You start one of your studies noting just how urgent these programs appear to be. About 830,000 women die from either pregnancy or childbirth-related complications every day around the world. And birthing appears, as you put it, to affect specifically poorer women. They are more at risk. So how did you come to birthing and to maternal health? And why are these phenomena important, both in Kenya and in the wider global context today?
Thank you so much, George. When you talk about social protection in maternal health, I know it's a global issue. The main reason why I settled on social protection in maternal health in Kenya is that we had a project that really wanted to investigate the perception of the community about government initiative to try to lower maternal health issues and maternal death in Kilifi County. We find that in Kilifi County, we have the highest percentage of maternal mortality. And because maternal health issues are a global agenda, you find that government of Kenya received a lot of funding from the donors, but now we wanted to know, how do community perceive these programs? Do they really speak to their needs, or is it the government initiative minus people's most felt needs? So being a young anthropologist, I was approached by this multidisciplinary project in Maseno, and I found myself in this project. And I spent quite some time in Kilifi, around 9 months, doing ethnographic fieldwork in maternal health issues. Yes, it's very important because we know maternal health, as I said, is a global agenda. And the global community is really campaigning to try and reduce maternal mortality, especially in Africa. And the thing is, as much as there is this campaign, but now, what about the most vulnerable? How do they perceive these programs? Do these programs reach them? So the main reason why I settled on the most vulnerable is when you look at the statistics and the magnitude of maternal death, you find that the most vulnerable, these are the people, women who, in terms of bargaining power, they have low bargaining power. So as an anthropologist, I went out there to give them a voice, to find out what do they say, and in terms of intervention, what do this mean to the government and the global community?
Yeah. You brought up Kilifi County, and I think we should tell our viewers who are not familiar with Kenya that this is a coastal county. And it's quite specific in the sense that it's both a place of tourism and intensified mobility and circulation, but also sharp inequalities.
Yes, thank you, George, for that reminder. Yes, Kilifi County, as you said, is along the Kenyan coast and attracts a lot of tourism activities. But again, if you look at the inequality perspective of it, you find that there's a lot of inequality in Kilifi County. And these populations are really affected by maternal health issues of access to services. When there are calamities like drought, this county is mostly affected. Despite the fact that they have good attraction to tourism, the community rarely benefit from this program. So we wonder, what can we do as upcoming scholars to ensure that these people are given voice? Whatever is there, how do these people benefit from these programs to actually curb this inequality gap?
These are such an important set of questions, and I wondered, and I wanted also our viewers to learn more from you about how you actually went about doing this research. What did it consist of? But related to that topic, I was also wondering how gender figures in the study of birthing. To name the obvious, we are now here, two men discussing birthing issues. So I wanted to know what challenges and limitations you might have faced and learned from, in a way, while studying birth.
George, that's a very important question. Thank you so much. The thing is, invading a space that is not man's space is very difficult. And when talking about birthing process, it touches on sexualities. And when you are in a community such as Kilifi, which is patriarchal, then negotiating and invading that space becomes problematic and very challenging to male researchers, male investigators, to say. So personally, as a man, it became a very big challenge until actually it took around 3 months for the community to accept me to study women. And I relied mainly on a female research assistant to help me introduce me to the community, help me negotiate women's space. But again, this female research assistant was very important because she was able to talk about sensitive issues with women. The main challenge that comes with this is that there is likelihood of misinterpretation. There is likelihood of seeing the normal things just normal, but because as a researcher, we are trained to look at normal things beyond normality. Yeah. But again, here is a young lady from this community who is likely to take things normal. So I find it was a bit difficult again to try to interpret what the research assistant gets from the women. But at some point also, I must admit that it was difficult, and at some point it was very difficult to get information from women. Men feeling insecure, a man invading space of women. But again, I'm happy because as anthropologists, we are trained how to invade the space that are a bit invadable. There are skills that we are imparted with to negotiate, to help us negotiate these spaces and get information that ordinary people might not get. But it was very challenging. Yeah, that's true.
I like your choice of the word invade, because it does in a way underscore just how nosy we are sometimes as anthropologists, but also the importance of this is something also of a feminist incitement. How do we look at the world, not just from the men's world, but learn from the perspective of women? And as you say, birthing probably in many traditional quote-unquote contexts is a form of knowledge that's passed. It's very gendered and passed down exclusively in these contexts. But at the same time, anthropologists are not alone. I'm wondering with the social programs that you describe and the kind of institutions working around it, they have already made birthing a form of knowledge that is not exclusively a realm of women. Medical personnel probably can be of both genders, or no?
Yeah, that reminds me of another important aspect, medicalization of birth,
Yeah, exactly.
Yeah, and when I talk of medicalization of birth, then to me, I see it as two competing narratives. So we have the medical narrative and social narrative. In social narrative, we have Fox taxonomies, how people refer to different challenges women go through during birth. And also we have the medical narrative where women, birth is seen as a health problem. And it in a way shapes how women seek healthcare services when they are pregnant, because birth has been medicalized that right from postnatal. When you get pregnant, you're supposed to do A, B, C, D according to medics, and people also have their own narrative. So we have two conflicting and competing narratives: social and medical narrative. And this is also a bit challenging also. Yes.
Yeah, that you bring up medicalization, it is not an obvious thing. Thinking as anthropologists now, it is not an obvious thing that birth and birth giving should be medicalized. But, and indeed now we see all kind of alternatives sort of in many places, alternative ways of giving birth, alternative institutions where you can pursue a non-biomedicalized form of birth giving. But birth is among the many domains, including sexuality, gender, aging, childhood, that have been extensively medicalized. What do you think are some of the effects, some of the implications of this biomedicalization of birth, at the expense, one might say, at other kind of forms of attending to it, other cultural forms?
Yes, that is why I said these are two competing narratives. We have the medical narrative and social narrative. And in social narrative, I'll again go back to Fox taxonomies, because people have what they believe in. And these narratives give women alternatives on where to seek care. We cannot run away from the fact that despite the fact that global community is trying to deal with maternal mortality, we still have women who rely on local institutions like the traditional birth attendants to give birth. And they really have trust in these traditional birth attendants. So it becomes a bit problematic when, the government is campaigning that we have free maternal health care, please go to the health facility and deliver. And again, we have social narrative which says, okay, if you are expectant, then you are allowed to visit traditional birth attendant, especially the very poor in the community who cannot even afford transport to health facility. So to me, I feel as much as birth is being medicalized, the social narrative also still takes precedence, especially when you go to rural areas, hard to reach areas. It's still there, and it's something which is happening we cannot run away from. We have these social institutions which are very important.
Yeah.
Yes.
And one wonders then also about the health risks that women themselves face in this day and age and how they might be different from previous. I mean, one of the questions I wanted to ask you was, anthropology has long been fascinated with birthing. One can easily claim that the process of giving birth everywhere, past and present, has generated all kinds of anxieties, all kinds of fears, fragility, what have you. I can think now of like some of the classic studies we've been reading from the very space, how it's being secured with spiritual protection, from the first bath water to what you do with the placenta, where it must be, how it must be disposed, what the meanings of that are, and so on. It seems to me that risk has always been there around birthing.
Yes, and we cannot run away from the I'll call it tocophobia. Tocophobia is fear of giving birth. And fear of giving birth, to me, it has deep rooting in the community itself, because, people long to have children, yes, but when they see what their sisters, their relatives go through, and here they are, they really want to have children, it becomes problematic, because now they develop this fear, and such kind of fear, it has its own risks on these women who are longing to have children. They can get pregnant. They have stomach pains. They can have prolonged labors, obstructed labors. And in the long run, if at all these women come from the low socioeconomic background, then the likelihood that maternal death or maternal complications may lead to diverse effects in the community among these women are very high. But we have two classes here. Tocophobia, regardless of class, women actually go through that fear of giving birth. But now it depends on socioeconomic opportunities and background. We find that women from I can say rich women, they know how to negotiate the system and where to go to remedies. When they go to hospital, they ask, please, can you induce this pregnancy? All those kind of things.
Yeah.
But for the low socioeconomic background, then women, they have these complications, and this is where maternal deaths are likely to occur. Yes.
So you're pointing to something very important here, that class, or if not class, wealth disparity really shapes some of the risks involved here. So in a way, that is one factor that makes what you're facing in Kilifi, but actually is a global phenomenon, somehow distinct in the presence. Access to wealth, but also probably information.
Yes. And I'll go back to what I was saying, negotiating access and institution shopping. I'm borrowing from Tobias Haller's work, institution shopping, trying to look for different institutions so that in the long run you're not left without anything, but you're able to access care. That's why we have rich women going to private and public health facilities. Poor women are likely to go to public and also rely on traditional birth attendants back in the community who they really trust that can do a good work.
This is actually a fascinating concept, institution shopping, because then it actually opens up the idea that birthing itself is not just medicalized, but also commodified, that you can shop for the services that you want, you can shop for information, or you can't.
Yes, you can shop, and in the institutional shopping, we have what we call bargaining power now. It is commodified, yes, the way you say, but now who has more bargaining power? Definitely, this is women who are socioeconomically well off. Yes, and they are likely to shop around, either go to private health facility, public health facility, private consultant, gynecologist, etc., etc. Yes.
Can I ask you to map out for us, especially through your project, but I think that what you describe here for Kenya is, again, quite applicable across the globe. What is the institutional framework around birthing? So there are state initiatives to, as you already mentioned, for social protection that might or might not work in different contexts. Are there NGOs who are attending to these same issues? And where do these bigger transnational institutions like health organization fit in this kind of landscape?
Oh, yeah. Thank you so much, George. The thing is, government of Kenya receives funding from World Health Organization. Some NGOs I know of receive funding from World Health Organization. And the thing is, bottom line is to attain the Sustainable Development Goals. We are talking about Sustainable Development Goal number 3 and universal health coverage aspect of it. So then when this funding are given out, then it is upon the government to initiate the programs. So it's kind of top-down approach, and people are not consulted. So that's why you find that despite the fact we have campaigns for mothers to give birth in health facilities, we still have mothers who give birth at home. We still have mothers who have complications, and along the way there is maternal death. The World Health Organization and many other international organizations go through the government and NGOs, and it's kind of top-down approach. I really look forward to having bottom-up approach where we ask the community what they feel they really need in terms of birth and maternal health care interventions, and then we work from the community going up. I think we can achieve the desired results in terms of lowering maternal death in Kenya and maybe in other contexts also.
And then to come back for full circle to what in your writing you call cultural practices. I mean, more specifically, the kind of, not necessarily, but of course, biomedicine is also culture, but the kind of practices that are effaced by biomedical interventions. And I just remembered a short anecdote in northern Kenya, somewhere around Maralal at some point, precisely because around struggles around the same issues that you described, there was an attempt to create a so-called Manyata maternity, where you create, Manyata is the traditional homestead, you create a traditional homestead so women from rural areas feel more welcome. It's not the kind of scary medical building of a hospital, let's say, but it's something more appealing. And yet it didn't work because the Manyata itself relates to notions of kinship, to whose life force is there, where do you bury the placenta, which is something that you describe in your work as well. So how do the women you've worked with see this tension then?
Yes, that's a very important concept. Right now, what I know, when I left Kilifi, we had maternal health sheds. These are built in the hospital. But I'm still going back to what I refer to as Fox taxonomies. People have their own narrations to what birth means and birthing process itself. So when you're trying to detach people from their community and you want them to be in the hospital for that period waiting to give birth, it's becoming a very big challenge. And again, I remember there is issue of kinship. When you direct mother from community to the hospital, there is kinship tie which is broken here. There is things that community believe in, and mother-in-law has a say in this, in terms of where will you give birth, in terms of when this is my first grandson, where will we take the placenta, socio-cultural issues. When we try to separate socio-cultural issues from the community to the hospital without actually consulting the community, then it becomes a bit problematic again. Because now people will resist going to these sheds. That's why you see the manyatas. People don't go because now if you don't really engage them from the word go, then it becomes very difficult for them.
Yes.
Yeah.
No, it's interesting because then the assumption also is that it is the mother as a sort of autonomous individual who makes a choice, whereas what you're describing here, or what your interlocutors are describing, is a more complex network of obligations, of expectations, in which this sort of decisions are negotiated or debated.
Oh yeah. And decision making is something key in maternal health care access and birthing. When a mother gets expectant, I'm talking from Kilifi County perspective and the Giriama community, if at all this is the first child, then it means mother-in-law, sister-in-laws, even the husband has more say than the mother. So mother is like a vessel to give life, but it's the mother herself doesn't have voice in all this. So the mother is used as a vessel. Then decisions on where to give birth, naming, and all these socio-cultural issues are left to the kins.
So the mother becomes a vessel for the lineage's reproduction in a way.
Yeah.
And then I wonder if the work that these multiple actors you're describing do on birthing align with other sort of NGO work, like NGOs, for example, on women's empowerment, kind of microfinance projects that seek to give women autonomy in rural areas and so on. Do you see this as overlapping?
Yes, I can say there is a bit of overlap because, again, the women who are very poor, there is an aspect of trying to sensitize them and empower them. And this is where women are encouraged to join the local rotating credit associations. Women join women groups, and in the long run, they get something. We call it individual birth planning scheme, so that when complication arises when they're expectant, they know where to go to. They negotiate access, and they have alternatives to seeking care other than relying on traditional birth attendant or public health facility. Then women can now make a choice because at least economically they're a bit empowered. So there is aspect of trying to empower this woman who is very poor in the community, but I feel it's at a nascent stage because not all women are reached anyway.
Yeah, but so you call them individual birth-giving schemes?
Yes, individual birth plans. Yes.
What are they actually?
Women are encouraged to prepare themselves in case of eventuality. So when they go for antenatal care, they are prepared psychologically that you need to prepare. You need to keep A, B, C, D, so that in case of emergency, you know what to do.
Yes.
So they are prepared in advance.
So it's an education initiative.
Initiative, yes. Especially by the health providers.
Let me ask you now, what do you then think, after having done this research for all these years, do birth and birthing processes mean in terms of a global agenda for change, health, care?
I love the word global agenda because now we have the global debate on universal health coverage. And we will only have universal health coverage when we try to consult the community. When we try to give the community the voice to rise up and say what they feel they really need in terms of birth and maternal health care, because where do we put these social institutions in the community, traditional birth attendants or midwives? They are very important people. How do we integrate them in the mainstream? If at all we integrate them in the mainstream and give them some kind of training, then I feel, and also with technological advancement in maternal health, I feel maternal mortality will be something to forget, and we will be able to achieve universal, SDG number 3, Sustainable Development Goal number 3, where we are advocating for health and well-being for all populations. But I will repeat that unless we look for a way of integrating these social institutions, which are very important in the community, in the mainstream, then the war and fight for maternal mortality is still far. But again, I believe in terms of technological advancement and inclusion of these traditional midwives, then I believe we will be able to win this war.
And then the idea of empowering midwives also is an idea of foregrounding forms of knowledge that are otherwise not captured by a certain kind of a top-down medical establishment. Just as a final question, where do then anthropologists come here? Right? This idea is fascinating and convincingly worth pursuing, of producing and foregrounding these other forms of knowledge and practice that could also expand what you call a universal sort of health coverage. Where do we come in?
Thank you. Anthropologists come in because in terms of giving it the cultural lens which is missing from other interventions. When we come up with a program and we miss the social lens of the people, because we are so much interested in people's culture, then it becomes very difficult even to pick up such kind of good interventions like free maternal health care when it doesn't sync to the people's needs, people's ways of lives, people's social institutions, which anthropologists are better placed in terms of explaining, then it becomes problematic. So we come in with a cultural lens, trying to interpret what all these policies mean to the people, and then we give this to policymakers. Yes.
As advice, as guidance. This is fascinating, and you give us a lot to think of and to motivate our work in the future. I do encourage our viewers, if they are interested to learn more about the topics we discussed today, to check out Stefan's publication. Stefan, I want to thank you very much for your time and insightful conversation, and look forward to many more similar conversations in the future.
Welcome, and thank you so much also.